We are going to discuss a very important topic today, that is Behçet's disease, and we'll come straight to it. Behçet's disease is an idiopathic multisystemic syndrome which is characterized by number 1, recurrent abscess oral ulcers, number 2, genital ulcerations, number 3, uveitis. Vasculitis is a key pathogenetic component and involves small, medium, and large veins and arteries. Unlike sarcoidosis, it specifically involves veins. Mortality is around 5% at 5 to 10 years, typically due to cardiovascular or CNS complications. The condition probably has an autoimmune basis and may be precipitated by exposure to an infectious agent. The subsequent cross-reaction. It typically affects patients from Turkey, the Middle East, and Far East, the ancient Silk Road route, and is strongly associated with HLA-B51. It has a lower prevalence in Europe and North America. The ethnic group with a higher prevalence of Behçet's disease also have a higher rate of HLA-B51 positivity. The peak age of onset is third decade. Reported gender prevalence varies with ethnicity. A transient hypopyon on a relatively white eye is a typical of Behçet's and JIA-associated uveitis. Systemic features are important, and the International Study Group for Behçet's disease, reporting in 1990, established the criteria for diagnosis, which is the most important one. A is the recurrent oral ulceration characterized by oral ulcers at least 3 times in a 12-month period, plus at least 2 of genital ulcers, ocular inflammation, characteristic skin lesions which are erythema nodosum, pseudofolliculitis, acneiform nodules, and papillopustular lesions, and a pathergy reaction, which is a pustule 24 to 48 hours after a sterile needle prick, which is 95% specific but often negative in European and North American patients. So, the standard criteria is recurrent oral ulceration, but in addition to that, 2 of the rest, that is genital, ocular involvement, and characteristic skin lesions and pathergy reaction should be positive. Then, patient presents in patients does not always conform to the criteria, and there can be additional features including vascular lesions like aneurysms, pulmonary and coronary, which can be very dangerous as well, venous thrombosis or thrombophlebitis. Arthritis occurs in 30% of the cases, though arthralgia is more common. Dermatographia, which similar to pathergy reaction, indicates skin hypersensitivity and consists of formation of erythematous lines following stroking or scratching, as seen in the picture here. So this is one of the characteristic features, and this here, this whole thing, this is dermatographia. Then are the neurological manifestations. 5% such as meningoencephalitis of the brain stem, dural sinuses, thrombosis, and cerebral aneurysm can be present, and gastrointestinal inflammation, especially ileocecal, and hepatic and renal lesions are relatively uncommon. Then, the part which is relevant to us, ocular inflammation, which occurs in about 70% and tends to be more severe in men, and is the presenting manifestation in about 10% of the cases. Signs are virtually always bilateral, and if not in presentation, they will eventually be bilateral. Relapsing, remitting, acute onset panuveitis with retinal vasculitis and often spontaneous resolution even without treatment is the classical pattern of the eye involvement. Retinal vascular disease, vasculitis, and occlusion is the main cause of visual impairment. Now, patient usually presents with acute anterior uveitis, as you can see in this picture, and it is usually bilateral, as we have uh, already discussed. It is not granulomatous. A transient mobile hypopyon is relatively in a relatively white eye is characteristic. This is characteristic. This here we can see hypopyon. And the eye is not red. Eye is relatively white. We can see the conjunctiva is white. There is no ciliary injection. So this is characteristic of both Behçet's disease and juvenile idiopathic arthritis. So these two signs are key indicator. And vitritis next is it can be severe and is universal in eyes with active posterior segment disease. Transient superficial white infiltrates on retina there. That heal without scarring may be seen during acute systemic disease. They may be deeper, more diffuse retinitis, similar in appearance to viral inflammation. Exudative RD can also occur. Inflammatory deposits analogous to KPs may be seen on inferior peripheral retina. So, anterior to posterior uveitis, which is anterior, then vitritis, then superficial retinitis, and then we'll go to phlebitis, as in this picture. So it can be arthritis as well as phlebitis in contrast to pure venous involvement in sarcoidosis, already discussed, can manifest with sheathing, perivascular hemorrhages, and occlusion. Vascular leakage may give rise to diffuse retinal edema and cystoid macular edema. So then comes the optic disc hyperemia and edema, which is also present in sarcoidosis. So raised intracranial pressure can lead to optic disc swelling and optic atrophy in Behçet's disease. Disc and retinal neovascularization may be seen as a response to inflammation and ischemia. And there are other presentations which are uncommon, including conjunctivitis, conjunctival ulceration, episcleritis, pruritus, and ophthalmoplegia from neurological development neurological involvement. Now, in the end stage, there is optic atrophy, retinal atrophy, and gliosis and sheathing. Now, this here we can see gliosis. There is already optic atrophy. Optic disc is completely pale. Actually, it looks like it's white. And ghosting of affected vessels here, where I put the arrow before. There is no blood in these vessels. The vitreous tends to be clear. Other complications include posterior synecdoche, cataract formation, glaucoma, and uncommonly retinal detachment and phthisis. Severe visual loss in males of up to 2/3 of patients at 10 years has been reported. This is probably much lower with aggressive management. The rate in women is about half that in men. Now, as we have already discussed, the most important investigation would be that of HLA-B51. Then comes the pathology test. Now, this is the positive pathology test. Formation of pustule 24 to 48 hours after a needle prick. Then inflammatory markers which are commonly done like ESR, CRP, complement levels, white cell count, they may be elevated. Thrombophilia screening is appropriate in some patients to exclude other causes of thrombosis. Fluorescent angiography delineates ischemic area and aids detection of posterior segment inflammation and monitoring of disease activity. Laser flare photometry of anterior chamber correlates well with fluorescent angiography in determining the level of inflammatory activity. Superficial lesion biopsy, which is synovial fluid aspiration, and lumbar puncture may be used to help rule out alternative diagnosis. Systemic imaging may include brain MRI, magnetic resonance angiography, CT computed tomography, angiography, and conventional angiography to identify ischemia. Now we'll come towards the treatment part of it. Immunosuppressants are the mainstay of treatment, of course, as we have discussed the pathogenesis. But availability and expense may limit therapeutic option in many regions. Topical steroids alone may be adequate if rarely there is no trace of posterior segment involvement, but usually posterior segment is always involved. Then systemic steroids and azathioprine at the dose of 2.5 mg per kilogram per day in combination are recommended for initial management of posterior uveitis in European League Against Rheumatism, that is EULAR, 2008 Behçet Disease guidelines. Steroids should be tapered slowly. Topical or regional steroids may be used. There may be a higher rate of ocular hypertension with the intravitreal steroid injection. Azathioprine may have a role in prophylaxis. Then comes the next drug, which is cyclosporin at the dose of 2 to 5 mg per kilogram per day, or infliximab in combination with azathioprine and systemic steroid. It is recommended by EULAR for severe eye disease, that is more than 2-line reduction in visual acuity and or retinal vasculitis or macular involvement. A recent study recommended a single infliximab infusion or initial treatment for posterior uveitis. Hypertension, nephrotoxicity, and neurotoxicity are concerns with cyclosporin, which should be avoided in patients with CNS involvement. Unless it is determined that severe eye disease warrants the risk. Infliximab may lead to activation of tuberculosis, and screening positive patients should receive prophylactic treatment, for example, isoniazid. Intravitreal administration in a novel is a novel alternative route of administration for infliximab. Now, next is the infliximab and adalimumab. They should be considered early for vision-threatening Behçet disease. American Uveitis Society recommendation. Interferon alpha, that is 6 million international units per day, subcutaneous initially and gradually tapered with or without steroid, is a EULAR recommended alternative to the cyclosporin and infliximab. Azathioprine steroid regimen for severe disease. It should not be used in combination with azathioprine as there is a risk for myelosuppression. Anticoagulants are not recommended. So that concludes our topic of Behçet's disease, and also from here onwards we will be discussing uveitis, which is caused by different infections. If you want me to continue with these lectures, or if you have any queries, I would like you to mention them in the comment sections. And thank you all Please like and subscribe so that we can help each other in learning the whole thing. Since the whole content is taken from the 9th edition of Kanski, I am looking forward to finishing the whole book and then reading towards reading the next book, that is Parsons' decision making in ophthalmology, and after that Snell's anatomy. So please give your suggestion in the comment section that which book should be read or which book should be discussed in upcoming lectures. Thank you.